Hi, my name is Richard Dobson. I'm a Professor of Health Informatics based here at King's, and I'm the head of the Department of Biostatistics and Health Informatics, and we undertake a large amount of research that utilises data, different types of data, in order to try to improve care. We're based within King's Health Partners. So King's Health Partners is an academic health science centre, one of only 8 within the UK. And this involves a special relationship essentially between the university, King's College London, and the hospital partners that are part of King's Health Partners. So this project is taking advantage of the fact that we collect huge amounts of data within the NHS constantly, 24/7. You know, when you go and see a doctor or see a care team, go to the hospital, you know that much of the time spent when you're engaging with the team is them typing information in. Now, gradually over time, that accumulates to be a huge amount of information. Now, often that information isn't really exploited or utilised. It just sits there. It's kind of one-way traffic, if you like. So what we're trying to do with this project, and what we've been doing, is building systems that actually surface that information, take it out of those hospital systems or make it available, and then people can start to derive insights from that and provide new learnings, new knowledge. We can turn this data into knowledge and then turn that knowledge into action that improves the care of the individuals that it was taken from. And we've seen these large language models start to appear that have lots of emergent capabilities and behaviours. We've all used ChatGPT, which is trained to be able to interact with you and chat with you. But we can, those kind of GPT models, if you like, have been trained on lots of information that's on the internet. And they've seen very little data that relates to real care, real clinical scenarios, real world practical care. And then we want to train or tune the models to develop specialist behaviours in certain areas, such as organising or understanding or being able to predict what might happen next for a patient, or predict what the best treatment might be for a particular patient, or predict which patient might respond better to a certain medication. The kind of large language models that we've trained so far today, we've trained on over 15 years worth of data, huge number of people from South East London, a very diverse population. And this GPT model has been trained to understand 190,000 different medical concepts. So that's whether that's diseases, symptoms, procedures, or medications. And so you can say to it, I have a patient here that has, is a certain age, at a certain age developed a certain disease, and then a bit later develop something else. So you can create this history and give it to the model and say, now tell me what's going to happen to this person, and it'll make a suggestion. But what we want to do in this particular project is make it a specialist in certain areas. We want to do this in a way that's safe and sets a precedent for future work. So there's a lot of concern about how we develop and apply and use AI within the healthcare system. So we want to set a precedent for how AI is used safely. And we're already working within the centre with some of the regulators within the UK around our existing models, and investigating the bias within those models, and kind of mitigating that. In terms of the patient benefit, we want to see people identified or diagnosed at an earlier point. And we want to understand as early as we can what is likely to be the course, the disease course or disorder course for their condition, because then we can provide the more tailored care, more appropriate care, the right medication for them, the right kind of support for them and their families. And therefore it's going to make that whole kind of drug development process much better, much safer. Motor neurone disease is a great example of a condition that we'll be able to focus on here. Classically, rare, but actually we're fortunate enough to be working with hospitals that are major centres of motor neurone disease care. And we have this data that's been collected over a very long period of time. So, close to 20 years in some cases. So we have this kind of extremely long amount of information, detailed information on each person. We also have multimodal data as well, so other type of types of data. Some of our centres have been collecting genetic data on these kind of patients over a number of years. This includes kind of sequencing of the whole genome. So this provides, different layers of information. So combining the electronic health record information with genetic markers that have been identified allows us to provide a much more kind of 360-degree view of the patient through these different kind of data layers that we're able to overlay. And so we'll be able to understand the kind of the various kind of patterns of disease and disease progression in people that have this kind of developed this terrifically horrific, disease. And understand how those change over time. We want to shift away from just treating everybody the same when they have motor neuron disease, to actually giving treatment that's more specific and tailored to them and their needs and what's likely to be the future for them and their progression of this disease.
My name is Vasa Churchin. I'm a professor of health informatics in the Department of Population Health Sciences at King's College London, and I lead the digital health group there. My research interests are in the application of informatics technologies to medical challenges. And specifically for this project, we're looking into use of process models in modeling clinical guidelines, which determine how patients are treated in our health system. Recently, there has been a drive to developing computable guidelines that can be digitized. So rather than clinicians working with these large text documents and flowcharts, they've got software tools that can read these guidelines, model them, and then give them recommendations on how to proceed. Specifically, this project is around building a validation framework for these guidelines within a context of an electronic health record system in a hospital or another health organization. Typically, guidelines are synthesized evidence that give us recommendations on how a certain condition could be treated in practice. So organizations such as NICE in the UK are in charge of synthesizing all the evidence that's available and producing step-by-step guides and flowcharts on how a disease should be treated in practice. So what tests should be done, what medications should be prescribed, what further tests should be done based on the outcome after a certain time. The problem with these is twofold. First, the evidence that they rely on comes from clinical trials, which focus on people with a single condition. And the second is that the guidelines themselves are very much restricted to a single disease, with possibly checks if a patient has another disease. In reality, what happens is that after the age of 40, 50, most of us have multimorbidities. The PhD project that we're proposing would be building up on that and allowing us to look into these computable forms of guidelines and map them onto the electronic health record systems in the hospital to see if the guideline has been followed, or alternatively, if we did the guideline slightly differently, is there an evidence base for it within the electronic health record system, and how did the outcomes differ between the two? So the impact of this project would be that it would give us means of following guidance uptake in different health organizations. This has massive impact on the global scale as well, because what we're seeing increasingly is that the countries of the global south and low and middle income countries in general, we see the digital uptake outpacing the economic development. So more and more countries which are still low and middle income, suffering from disease silos, poorly organized health systems, they still get digital embedded. And we can deliver really impactful interventions in there using digital, using guideline implementation, for example, that will make a step change for the people there. It is the first PhD project funded under the Science Card collaboration for Drive Health, and it fits into the sustainable healthcare systems engineering theme, where we build sustainable, scalable solutions that will enable further research and deliver step change in the way health data science operates in the UK.